Hi, this is Irene Owens, and this is Pediatrics. And these slides are from Nicole Tenney. Miss Tenney is one of our pediatric nurses as well as I am, and she shared her slides with me. So I always like to give her credit. She's a doll. So anyway, when we talk about pediatrics, we just have to talk about Big Bird and all Big Bird's friends. So I thought that was kind of a neat little thing. And you can, I don't have the background music to the Sesame Street theme song, but you can play with that at home. Remember that pediatrics is all about families. And remember that a family is a group of people living together or in close contact who take care of one another and provide guidance for those dependent members. And a family is whoever the client considers it to be. So whenever we look at families and pediatrics, we're looking at them as a whole. Family-centered care, it's the remember you're caring for more than that one person. So usually the children are the easiest to take care of. It's the parents and the grandparents and the extended family. So you have to have excellent therapeutic communication skills when you're talking to families, and just listen. You know, they'll tell you exactly what they need. Your professional nursing roles are I have the pages down here. This is for your new book. It's for the new edition. It's pages 16 through 19. This is basically when we talk about the professional nursing roles, we're talking about the provider of care. You're going to provide care for the patient and the family. You're a critical thinker, which we've already gone over. Effective communicator, very, very important. You're a teacher. You're a collaborator, and you're an advocate for that patient and family. So our family units, there's many different kinds. The nuclear and extended family, you know, you have a married parent, you have a single parent, you have the same-sex marriage, you have the married, blended, cohabitating parent or family, and then you have a no-parent family. And then there's all kind of variations within that as well. I have the YouTubes on Blackboard in this week's content. So if you want to go into that, and I think I named it exactly what this was. Remember, we have to take into account our family culture characteristics and our communication pattern. We always have to incorporate their culture, and make sure that you're aware of your own biases and your own ways of thinking. Health beliefs and practices we always have to look at, and their religious background, their cultural background, and their socioeconomic orientation. So subjectively, we're going to get the health history, and that's usually from the mom or the dad or the extended family. Their patterns of daily living, so important because children love ritualistic types of behavior, and that makes them more comfortable in their life. So we have to make sure that we kind of mimic that, hard as it is, mimic that type of behavior in the hospital setting. And then we have to do the review of systems. And the review of systems, as you all well know, generally we're gonna, has the baby lost, or the baby gained weight, did the baby have any chills, have any fever, skin, any rashes, any open areas, any diaper rash, maybe they have thrush, and they've had diarrhea. Well, they have candida, and candida goes from the tongue all the way to their little bottoms. So we have to check their skin, ask the parent about the skin, ask the parent about the head. Remember, the head, a 12-month-old, that anterior fontanelle is still open. It's going to be closing, but it still is open, and you're going to feel that. And the ears, you check the ears, if there's any problem, any tugging at those ears, any teething. How's their nose? Is there any discharge from their nose? Are they coughing? Are they drooling? Those kinds of questions. Neck, look and see, ask if there's any problems with their neck. Chest, any problems with the chest area, any problems with breathing. Do they notice any intercostal retractions? You won't ask them that way, but do they notice their little shoulders going up and down? They notice any nasal flaring? Cardiovascularly, do they turn blue around their mouth? Do they notice that they hold their breath? Do they notice any discoloration of their extremities? GI, their bowel movements, what's normal for them. GU, how many diapers do they usually change, and how much do they eat? It's very important. How many bottles they get, what kind of formula they have. They are given, if they're breastfed, if they're bottle fed, if they're taking solids yet. Musculoskeletal wise, depending on how old they are, because when we go through all these slides, we're looking at developmental ages of children and a predictable pattern to their growth and development. So we're looking at their bones neurologically. Are they up where they need to be? And endocrine wise, we need to look at if there's any hot or cold intolerance. There may be a thyroid problem. Their heart rate, can go up with hyperthyroidism, or if they have hypothyroid, or a congenital anomaly when we look at the review of systems with children and infants. So objectively, we have the developmental milestones, and so important, because those developmental milestones are something we have to pay real close attention to, because they do follow a predictable pattern. There is the Denver Developmental II screening test that you can use. Anthropometric measurements are growth charts. Vital signs are real important, and vital signs change as the child goes from infant to adolescent. And of course, we always look at our psychosocial development and Erikson's, and we look at the temperament of the child and any kind of age-related variations in the child. You may expect, the 10-month-old to be pulling up and trying to waddle and walk, and maybe this 10-month-old is overweight, and he is walking, but he has little bowed legs. So we're looking at, okay, he should be walking, but he's bowing. Now, is it musculoskeletal, or is it because of his weight? And it usually is because of his weight. So those are things that we're going to be looking at with our children. Remember, our stages of growth and development are newborn and infant, birth to 12 months. Our toddler is from 1 to 3. Early childhood, preschool is 3 to 6. Our school age is 6 to 12. And then adolescent is 12 to 19. So you should have parameters in your mind when we talk about a toddler, talk about a preschooler, what's going on with them. Your developmental assessment, your Denver developmental screening identifies the 4 areas that they evaluate: personal, social, fine motor, language, and gross motor. And it gives you a chart in your book on the developmental milestones and exactly what they do in each specific one. Our anthropometric, I never can say it right, measurements: length, weight, your BMI, your head circumference, your skin fold thickness, and your skin fold thickness measurements. So length and weight are very, very important, and those are usually charted in the growth chart as pediatric nurses. Vital signs: temperature, pulse, respirations, blood pressure. Blood pressure isn't as diagnostic and as is pulse, respirations, that temperature. Not to say that it's not, because if you have a baby that that has maybe coarctation of the aorta, they're going to have blood pressures that hardly are anything in their lower extremities, and they're going to be very, very high in the upper extremities. Blood pressure is usually very, very low, and you should have some idea of the different developmental vital signs that a baby's going to be a whole lot different than an adolescent. Blood pressures are going to be low in an infant, sometimes 70 over 40, 80 over 50, whereas an adolescent is going to be more like 110 over 70. Heart rate is usually up with our younger children, and then it plateaus at adolescence. Temperature and pulse, that temperature goes up, that pulse goes up. Children usually have more respiratory type problems than they do heart problems, unless they have some kind of congenital malformation of the heart. So it's always looking at respiratory wise. Is respiratory rate up? Are they nasal flaring? Is the baby having intercostal retractions, substernal retractions? Of course, we go back to the psychosocial development, Erikson's, that trust versus mistrust, and that's from birth through 1 year, and just meeting their needs at this point is adequate. And this is the foundation for the rest of the psychosocial development. The 2-year autonomy versus shame and doubt. This is centered around an increased ability to control their bodies and themselves and their environment. It's all about do it myself. Do it myself. I want to do it myself. Walking, climbing, decision making. They learn by imitation. And the shame comes when they're made to feel self-conscious or small about what they're doing, and they're not allowed to do things that they're capable of. Your initiative versus guilt, explore the world with all their senses and powers, and they begin to have a conscious and an inner voice. 6 to 12 years is industry versus inferiority, and they want to do tasks that they can complete. They need achievement. Inferiority comes when expectations of them are too high or that they feel they can never measure up. And then they're 12 to 18-year-olds. They have identity versus role confusion, and they're concerned about how they look to others. Temperament, usually at birth it's a response to their surroundings, and as a baby their caretaker in their environment kind of mimics what their temperament is going to be. And you look at the mom and the dad, the temperament that they have is usually the temperament of the children. There's all kinds of age-related variations in children. The sensory, physical, cognitive, language, and moral age-related variations. But remember that they do have a predictable path developmentally. On overall assessment, unless it's an emergency, don't rush in. Establish rapport with the child and the parent. And if the parent trusts you, the child is more likely to as well. They will take their cues from their parents. So everyone is really tense when a child is ill, and you need to diffuse that with a very calm attitude, and be very sensitive with the information, and be prepared to explain things several times if necessary because of the stress level of the patient and the family. So ask questions, do a comprehensive health history, family medical and social history, PMH, past medical history, immunizations, developmental milestones. Their ADLs, real important for children because ritualistic behavior is very important to make them feel secure, and do those overall do those overall, I'm sorry, I think I went too far. Let me go back here. Overall, yeah, here I am. I'm sorry. And the review of systems, real important. Children, depending on their developmental age, like a 10-month-old, I would approach a 10-month-old because I know that they're going to be sitting in their mom or dad's lap, and when I come into the room, I'm going to keep my distance. I might do a little peekaboo, with them. I'm not going to go and grab them and put them in the crib right away. I'll probably let them play with something that I have, and get a little bit closer and know that the parent is trusting me, that I can get a little bit closer to that child, because children will back away from you very, very easily, especially if they're in fear, and their fear of separation anxiety from the parent, and they have stranger anxiety as well. So in physical assessment, you have to use all of your senses, observation skills, smell, and touch. You can find out a lot about a child just before touching them. Observe their behavior. The first sign of illness in children is almost always behavior. Note their interactions with their family members. Make sure you have to be a good observer. So the touch is usually the last in our physical assessment because we're evaluating the patient and the family as well. So this just goes over the different physical assessment, the skin assessment, head, neck, and you can go over that in your reading. So our general principles, we're never going to lie to a child, especially about painful procedures. Any distrust will destroy that relationship that you have. So never lie to a child. Engage their help. Remember that, especially small children, they love to be helpers. Our little toddlers, our little preschoolers, they love to help. Let them touch and feel, handle the stethoscope, listen. It's very important that they get to do that. Treat assessments like games. The peekaboo is, really kind of a neat little game if they're about 6 months old to 12 months old. And anytime you can always use, I think it's real important that you remember that use like a doll, a toy, to be kind of that transition object between you and the patient as you're talking to them and as you're introducing yourself and trying to do a physical assessment. And just remember, if it's going to hurt, you got to tell them it's going to hurt. Health promotion on our infant and child. Remember, nutrition is important. They usually, and I think I have another slide here about nutrition, but usually about age 4 months you can introduce some solids. The American Academy of Pediatrics a lot of times says, well, not a lot of times, but does recommend that you try to just give them breast or milk, not milk, but formula up until a year. But you can't introduce solids, and you want to make sure at around 4 months that they introduce, if they're going to introduce solids, they introduce it one at a time. Dental is very, very important with our children, and it's important that you teach mamas and dads and extended family that they need to be brushing their teeth twice a day. So they, if you're in there brushing your teeth, they need to brush their teeth, especially as little toddlers. Sleep and rest is always important. Immunizations, of course, are important. And it's really a little scary because a lot of homeschool children are not getting their immunizations as children that are in school because they have to provide documentation of it. There's also health screenings such as lead poisoning, and lead poisoning is still apparent in some families, in some homes. So nutrition, this is just a little break from the lecture, but there's the Flintstones talking about nutrition and vitamins and how important nutrition is. And you have to remember, toddlers and preschoolers, a lot of times they're not gonna want to just sit down and eat. They want to just help themselves and go, and that's okay. When they're hungry, they will eat. But we've got to foster that autonomy with our toddlers. And here's the food pyramid in kind of a kid's form, kind of a neat little to eat right, exercise, and always have fun. So our health promotion in our infant and child nutrition: at breast or bottle, whole milk at one year of age, solids at least at 4 months, finger foods about 8 to 12 months. And begin to use a spoon between 1 year and 18 months. And age 3, there's the food pyramid, for our kids. But I think I mentioned how important it is to introduce one solid food at a time, and to make sure that with our children, especially, and we'll go into that in a minute, especially with our kids that are a little bit older, to let them feed themselves, even if, with those finger foods. So teething, those little ones are gonna drool, they're gonna be irritable, chew on objects. That's how they get to know their world. They have crying episodes. That's the only way they can communicate. And they have disrupted sleep and eating patterns when they teeth. Dental caries are our health of our teeth is very, very important. In 2001, CDC sponsored screening of third grade children attending 26 New Hampshire public schools and found that 52% had tooth decay or dental caries, and 22% had untreated cavities. It's really a horrible, horrible thing when our children start off with dental decay, and there's not a whole lot of help, especially for our adult population. So it's going to be difficult. Sleep and rest. Newborns are how important that is with our newborn, and some newborns sleep more than other newborns. Our little infants, they love their little naps, and usually they're sleeping through the night. Toddler and preschoolers will usually go to bed between 8 and 10, get up about 7. They'll have a little nap during the day, especially if they're active. And school age are basically sleeping around the same time as but they never want to go to bed. School age don't, and adolescent will never go to bed unless they sleep, all day long. So this just gives you some health promotion, infant, child immunizations. You do not have to, do not memorize this, because there's no way that you can. But know that it's here. Know that you always have a reference for immunizations, and immunizations change all the time. So it's important that you know that immunizations are important. There's a lot of discrepancy between MMRs and autism, and they haven't found that there is a correlation. But who knows? 10 years from now, we might. But usually the benefit outweighs the risk when we have immunizations. Just know that our homeschool children are the more at risk for not getting immunizations. So our little health promotion for infant child, there's the social aspects of play, and those play activities for children is very, very important. There's the solitary play, which is your infant. They stimulate sensory motor development with simple imitative type games. The onlooker play watches others but have no interaction. The parallel play comes in with a toddler because they're independent with their play with a similar toy. Associative play, they play together, but it's not very organized. And then we have the cooperative play, which is more like the school age adolescent, which is organized play. Remember, play is the work of the child. Whenever you want to elicit any type of what's happened in the past, any kind of behavior, make sure that you incorporate play in your plan of care, because that's where you're going to see how actually the patient feels about, how the child feels about a certain procedure maybe you did on them, or a certain occurrence that has happened in their past, if there's any sexual abuse, in the family. Health promotion for adolescents. Of course, nutrition is important. Obesity is on the rise. Our dental care is lacking. They never want to go to bed at night, and then they never want to get up in the morning. And all the eating disorders come to play. Our anorexia nervosa, which we'll talk a little bit more later, and bulimia nervosa are some eating disorders that have a psychological reason. We haven't really found out any other kind of factors or reasoning for those. But obesity, our 14-year-old is going to have self-image problems, and we look at these the adolescents that don't exercise, that have been overweight since they were small, and you look at the parent and the family, and the parents and the family, and they're all overweight. It's like they don't even, they don't have a chance. And kids can be very mean, very, very mean in high school. So we talk a little bit here about parenting styles. The dictatorial type of parent controls the child's behavior, very, very strict rules and standards of behavior. This child can be very sensitive, very self-conscious, very submissive, could be loyal, dependable, honest, or can be rebellious because of this, and antisocial. The permissive or the laissez-faire, the parents exert very little control over the child's behavior. The children control the parent and are disobedient, disrespectful, irresponsible, aggressive, and defiant. The democratic parent usually combines practices from both of the extremes by directing their children's behavior and attitudes, and emphasizes rules and lets them have consequences to those rules. And usually these children have high self-esteem, they're very self-reliant, they're assertive, and they're very inquisitive. So misbehavior stretches the limits of children. Minor consequences are very short-term frustration, and those major consequences are child abuse. So parents have to have a really fine line in helping the psyche of their child as they correct the misbehaviors of their children. This is a YouTube that I've incorporated into the week, and it's Misbehavior by the Gene family. I think it's the nanny. This one's the nanny one. And the nanny has some great ideas, and it's not just about helping the child, but it's basically teaching the parent how to be in control of the child in a very supportive and nurturing way. So there's different types of discipline: redirection, reasoning, timeout, consequences, behavior modification, and corporal punishment. And you have to remember that children view themselves the way their parents view them. A wild child is going to be a wild child. It's kind of a self-fulfilling prophecy. discipline is designed to teach a child how to function effectively within society, and parents' goals should be to help the child feel loved and capable, and setting limits to enhance that sense of security until the child is capable of understanding family values and self-discipline. So when we do redirection, the parent removes the problem and distracts the child with another activity or object. And that's usually from infants to pre-adolescence. Reasoning explain why the behavior is not permitted. Now, we don't want to do that too much with a toddler, just because they're just not developmentally there yet. You know, maybe a preschooler and a school age is a good age to do that too. Timeout is remove attention that's given to the child that's misbehaving, and you have to remember that with timeout, we need to put that child in a hallway, nothing that's going to stimulate that child to be bad again. And I think there's also another YouTube that I have on that. Consequences, learn direct results of their behavior. And these are from toddlers to adolescents. They have to learn that there are going to be consequences. If they touch something that's hot because you left the handle of the stove, there's going to be consequences to that, and it's going to hurt them. That's the natural spontaneously, that this hurts. I fell down, this hurts my knee for the toddler. The logical one that's directly related to the behavior, and the unrelated, purposely imposed. And behavior modification rewards positive behavior and ignores the negative behavior. And sometimes that's one form of discipline that you can just, because if we keep paying attention to that bad behavior, then they're going to keep doing it because that's the only time that we ever pay attention to the child. And corporal punishment is spanking. And the American Academy and Pediatrics assist in developing some other forms, of discipline instead of corporal punishment. So our discipline with our newborn and infant is in teaching, helps with overall function as an individual. Limit setting, personal child rearing practices are usually used, and expectations for each developmental stage is important. Remember just to keep the child, keep the infant out of harm's way. That's the major take-home message that we can give to our patients and families. Discipline in our toddler, we teach socialization and safety to our parents, and safety is huge with toddlers, and we have to be consistent, and we have to remember that toddlers think they know everything, but they do not know everything. We have to be with our toddlers all the time. We can't have anybody else in charge of them. You have to have firm structure with safety limits, be flexible, with those limits, because we have, remember, their autonomy versus shame and doubt. So they have to be able to fall down and get up again. However, we can't just let them go out in the street and fall down and a car runs over them. That's what I mean by be flexible with limits. Concrete versus realistic. They're very, very concrete. So we need to make sure that we tell our this will hurt you, owie, those kinds of things. Can do does not equal wants to do, and you have to praise them. Have to praise those little toddlers. Temper tantrums, you can go to YouTube, and there's a real cute thing about temper tantrums, and that is also in your course content under videos. Discipline in early childhood. Actions have consequences. Explain the rules beforehand. Consequences equals behavior that you will be punished for. Timeout is very important. Chart stickers, stars, they love that. Encourage those good behaviors, and it helps them regulate their own behavior as you give them those consequences. There's another YouTube that's on your course content videos that you can look at. Discipline in our school age, they usually internalize rules. They're more independent. There's natural consequences for their behaviors. And it's important that we teach parents, and we do this for our own children, that not rescuing. We cannot rescue children from their own consequences. They have to make their own mistakes as long as it's in a safe environment. Not all understand the responsibility or ignore consequences. Sometimes parents rescue their child because they don't understand the best outcome for their patient. And they can be in timeout, or they can be grounded. That's a good form of discipline for school age. And our discipline for our adolescents, they internalize responsibility. They need parental support for rules. They don't think they like limits, but they need limits, and they really do like the structure and limits of rules and responsibilities. They have positive behavior should be the focus always with any of our developmental stages. And one form of discipline is to remove privileges, from the adolescent. Okay, this ends part 1, so I'm going to take a break and pause, and you can too. And part 2, I've divided this up between 1, 2, and 3, so you can take a break in between. So I'm going to pause and then get back with you. Thanks. Okay, so we're back, and sorry, I forgot to put my microphone on. So we're back, and we're going to talk about verbal communication. And remember that verbal communication includes language and vocalization, such as laughs, moans, words, anything like that. And words define reality and can be very powerful. It's important to learn how to recognize how patients and healthcare professionals use language to manipulate reality, and also important to know how to change those perceptions and communicate effectively. Our nonverbal communication includes our pitch, pause rate, volume of speech. Children understand tone, and they understand the pitch before they understand the meaning. And children are sensitive to nonverbal, a lot of nonverbal cues, our facial expressions. They understand that before they, just like animals, they understand that before they understand the word meanings. Family-centered communication is important in pediatrics. Establishing rapport, availability, and openness to questions. Family education and empowerment is important. Feedback from children and families. Management of conflict. And spirituality is very, very important. You have to be open to questions from the family. You want to encourage the family to ask questions. Don't immediately leave the room after doing any kind of procedure. Don't rush the family. Make time to discuss the concerns with the family. Have the patient or the family write down questions. That's important. Empower them. It's real important that you empower the patient and the family as you're dealing with families that are in an uncontrollable situation when their child is in the hospital. These slides just kind of go through the communication development of the different developmental levels. This is the infant. I'll let you read those on your own. The toddler, remember they're the I do, I want. Communication development in the preschool age. They're the Ys, and they have a very short attention span. Communication development with our 6 to 12-year-olds. Remember, they are able to describe concepts, thoughts, and feelings. They like to follow the rules. So we need to tell them in the hospital, when they're in the hospital, what the rules are and incorporate them in our care. And communication with our adolescents, they have adult concepts. They need to belong to a group. So group is very important to them, especially their peers. Special needs children, you have to in special needs is you have to assess the physical, mental, and developmental abilities and then determine the most effective methods of communication. I worked a lot with special needs children, and they could be 16 years of age, but developmentally they're in the infant stage. So you have to look at the psychosocial for trust versus mistrust, and know how does an infant usually communicates through moans or crying, and what kinds of things you can do to facilitate their needs, because you have to meet their needs at that age. Child safety, hugely important, very, very important. And remember that we need to talk to our patients and our families about medication storage, crib safety, smoke detectors, car seats. Car seats are real important, and we're going to go over that again. Drownings, falls, poisoning, choking, burns, safety helmets, any environmental factors are real important. So safety is utmost with our infant and child. Adolescent safety, accidents and injuries are high on the list of problems with adolescent safety. They're very high risk behaviors. Driving, they start driving, so motor vehicle accidents are huge. Bicycles, firearms, water, reproductive, substance abuse, violence, tattooing, body piercings. These are all issues that happen with our adolescents. So our common stressors during hospitalization is separation anxiety, loss of control, bodily injury, and pain. Separation anxiety, especially in our preschoolers and toddlers. Toddlers have the most separation anxiety. Sometimes at preschoolers, especially age 5 or 6, they have a little bit more reasoning than our toddlers do. But it's definitely a loss of control. And you remember that our toddlers have that magical thinking, go back to their developmental stages. And they're afraid of bodily injury and pain. Some of them will think that if they get a shot, then all their blood is going to come out because they're going to have a hole in their body. So they have a lot of magical thinking, unrealistic thinking, but it is, their developmental stage that they're at. Separation anxiety, the toddlers, they cling to the parents, they beg them to stay. They may be angry at the mom if she leaves, and the father stays. So you'll see some real negative behaviors with toddlers. So our intervention is to encourage the parents to stay, usually cots in the room, bring objects from home. Remember, I told you they're very ritualistic. And if the parent can't stay, the nurse becomes the caregiver. So you have to build trust. Trust is important no matter what age you have with your patients. Preschool, usually not quite as intense in their separation anxiety. Sometimes children get labeled as spoiled or a brat, but these are normal stress responses. So the intervention's basically the same as for a toddler. You have to gain their trust. School age, they usually handle separation well. Sometimes you have those who don't cope well, and they may not ask for help, and they may not express their feelings. So it's important that you intervene, make sure families bring objects from home, pictures, radio, Game Boys, whatever, their pajamas. Look at a child as an individual and provide continuity of care for that patient. Adolescents, they're geared more towards separation from their peers and their usual activities. They're lonely, bored, depressed, can act against the nurse, and sometimes they can be a real challenge. And it's important to remember that with our adolescents to provide association with peers. Anything with a peer is real important because use of the phone, usually they have a lot more relaxed rules, but anything with a peer will help them gain some sense of control and gain, also just a feeling of not so helpless. Loss of control are toddlers. Remember, autonomy versus shame and doubt. They can have temper tantrums. And especially we ask them to lie down, and it's very hard for them to lie down, and especially because we're going to be putting in our IVs. They don't like them in. They don't like their change in the routine. Interventions are good, or a good admission assessment will help to find those rituals, those routines, bring their favorite items from home. And remember, there's a forced dependency that they're fighting against. So it's important that the child make decisions when possible, such as any kind of games or drinks that, like if you're gonna give medicine to a toddler, you don't ask them if they want to take their medicine. You just say, it's time to take your medicine. Do you want orange juice or apple juice? So you just give them some choices. Our preschooler, they like magical thinking. They're fantasy superheroes. They usually exaggerate what is happening to them or what is really happening to them. And remember, it's the initiative versus the guilt. And they view the hospital as punishment. Take me home and I'll be good. So remember, those interventions or allow them to make decisions, explain everything, and do not use any threatening words or actions. School age is industry versus inferiority, and they're very vulnerable to loss of control. They feel that they need to be productive. So our intervention is have them participate as much as they can in their care as possible, allow them to make decisions and explain things in advance, and allow for any questions from the child. And adolescents, anything that threatens their identity, and hospitalization and being different, if they just were diagnosed with diabetes, anything that's different will threaten them. Explain procedures, take time to prepare themselves, and know what their present needs are is really important. So the role of the pediatric nurse is basically whatever the needs of the child are. So we want bathing and safety is important. Sick child has the same hygiene needs that an adult patient would. So being sure to remember oral hygiene and good peri-care is important. Safety. Children require greater concern for safety. Armbands are very, very important. You never, crib rails, side rails, up or down, very important. You never leave a child in a crib or on a table unintended. Electrical outlets should have safety plugs in place. Use care in positioning the equipment around the crib so that the child doesn't pull something dangerous into the crib with him. IV arm boards, if they're necessary, they're considered a restraint. So must be very careful of any disposable pieces of equipment, such as the needle caps, because they can choke on that. Toys should not be small enough to place, in their mouths. Clothes shouldn't have any buttons on them. You have to think about there's no hot dogs, no hard candy, anything they can choke on. Baby powder, if used, should be cornstarch, not any kind of talc. Balloons, they should be mylar and not latex. And don't use gloves as balloons because of the latex allergies. Feeding a child is always a problem in a hospital, but don't force. Serve those real small, frequent meals, and make sure that you document the intake. Fever control. Antipyretics are usually given for fevers 100.4 or higher, depending on the diagnosis. Each case is different. So you got to make sure that you know what the physician is looking for. Tylenol is appropriate for weight. Remember, no aspirin due to Reye's syndrome. So no aspirin, especially if they've had any kind of viral infection, chicken pox, anything like that. So no aspirin. Ibuprofen you can use that can control high temps. You can alternate with ibuprofen and Tylenol. Environmental control, make sure that you remove everything in their crib. And if they're running a fever, make sure you have the child or infant wear something lightweight. It's important that tepid baths are no longer recommended. Cool cloths, though, to the forehead and the neck is acceptable. Remember that most of your temperature for children is not serious, but it's usually beneficial. But just make sure that you reiterate no aspirin. Very, very important. Any infant that's less than 3 months old with a fever should be seen by a doctor. And increased fluids, very, very important when you're looking at fevers in children. I think when we talk about kids, we have to always say, first, do no harm. We have to minimize separation from the family, and especially the primary caretaker. Promote a sense of control, if we can, and prevent any kind of bodily injury or harm. So what can the nurse do for the ill child and family? And in our assessment, we need to look at the needs of the family, seek the family's advice, keep open communication, always address their concerns. We have to develop trust, positive reinforcement, and ongoing evaluation of that plan of care is important. When we prepare the child for procedures in the hospital, we need to know the patient and the patient's needs and developmentally where they are at. Provide information in terms that they can understand. Provide support for not only the child but the family. Let the child know it's okay. He can scream as long as he doesn't move if you have to start an IV. Praise the child and allow the child to perform those procedures. You've got to use what you have. And the toys, remember I said, play is the work of the child. So if you incorporate toys or dolls in your plan, then they'll understand it more before the procedure and after the procedure, because it's kind of fun to watch children as they perceive what's going on after after the procedure. And then it tells you about their feelings about what happened to them. Pain assessment and management, assessment of pain in infants. The parent is the key. Requires frequent assessment. Remember, pain, there can be some kind of cluing, such as squirming, jerking. Sometimes infants will just retreat into themselves and just fall fast asleep, and it's like they don't want to have to deal with anything. So you have to look and see what those behaviors are. In toddlers, they may react to non-painful procedures as violently as they do those painful ones. Explanations do not help with toddlers. They have an intense emotional upset and physical resistance, and they can be overly reactive. And they can point to where they hurt on themselves, or maybe even on a doll. Preschoolers are very vulnerable to threats of bodily injury because of their magical thinking, and they respond well to explanations. And usually they're a lot more verbal, and they'll tell you they hate you, and that's okay. And they also can use a face scale, so they can tell you how unhappy they are, and they will. Children are very, very truthful. School age, they're less concerned with pain than they are with disability or death, because death definitely has become more concrete to them, more real. Ask questions, they listen, they're very attentive. They may try to postpone whatever's going on, and they usually tolerate it well, but it's very stressful, and it's important that you provide privacy for your school-age child. Our adolescent body image is number one concern. They don't want to be different from their peers. They require privacy. They need reassurance that everything is going to be okay. And their self-control about pain is more adult-like than the other. Pain management in the verbal child. Question the child. Use a pain rating scale. You can use a FACES. If they're 3 years old or less, or you can, if developmentally they're 10 and developmentally they're 5, you can use the FACE scale. Look for behavioral and physical signs of pain, any pre-verbal behavior changes, vital sign changes, and always secure the parent involvement, and that's all about trust as you develop your trust relationship. And look at that cause of pain. Could be anything, could there anything else be going on with them? And take the action and evaluate the patient, both pharmacologically and non-pharmacologically. That's important. Pain management techniques are non-pharmacological, could be relaxation, distraction, cutaneous stimulation, just rubbing the, maybe they're complaining of their knee and just rubbing that knee. Sometimes the mama just rubbing the back of the child that maybe has abdominal pain. Those kinds of things are important. And our pharmacological measures: use pain medications preventively, avoid IM injections if possible. IV is better, or if they have an IV, or PO if they can. Always prepare your patient, always tell the truth. Evaluate your interventions promptly and reassess frequently, just like we do with our adult patients. Okay, so that ends part 2 of pediatrics. So we're going to pause and have a break and then resume. Okay, we're back, and we're back on our last part of the pediatric lecture. And we're going to talk a little bit about each of the some about each of these disorders that you'll commonly see in patients that come into the hospital, or you'll see for their developmental age. And the first one is failure to thrive. Failure to thrive, it can be from organic or physical ailments, and that's what you have to rule out first with failure to thrive. If a child comes in and they have not doubled their birth weight by 5 to 6 months, tripled by a year, and that's important for you to know, then we're going to be looking at how come they're not thriving, how come they are not able to take the nourishment that they need in and grow and develop in that sequential stage. So we always look at organic physical ailments first. How come this patient is not gaining weight? How come the little one's not gaining weight? There could be a non-organic cause, but we always have to look at the organic cause first. And it could be a maternal-child attachment, that maybe there's no bonding and the child has not bonded to the mom, and the mom hasn't bonded, or both. And there also is what they call an idiopathic, just unknown. There's a unknown reason why the child has not gained any weight. But remember that our 5-month-old, usually they double their weight, and by a year it's triple, and that's normal. And SIDS is the sudden death of an infant younger than 1 year of age. Their peak age for SIDS is between 2 and 4 months of life. They have associated with pulmonary edema and intrathoracic hemorrhage on autopsy, and usually there's no sound that's usually made at the time of death, so it's very hard for parents, because they blame themselves because they didn't hear them. But most of the time there's no sound that's made. Make sure that you teach parents that the child needs to be on a firm mattress. He needs to be on his back. Very important. Avoid any kind of secondhand smoke. Secondhand smoke is so detrimental to children. It causes infections, it causes asthma, it can cause, they're looking at it for causing SIDS. And it's important also that we do not share, you teach the patients not to share the bed with their child, because they can lay on the child and cause them not to breathe and cause SIDS. Autism. Usually males versus females. They usually have an abnormal EEG, cerebellar hypoplasia. The cerebellum is not as developed. Permanent intellectual and behavioral deficits. And they usually have bizarre interactions, communications, and behaviors. And remember, if you've ever seen Rain Man was an idiot savant, and very, very smart in some things, but not smart in a lot of other ways. Autism is, a lot of parents have thought that it was associated with the MMR, but that has not, research-wise, has not been found. Accident prevention, very, very important. Motor vehicle safety, it's important for you to remember that rear-facing car seat until they're 20 pounds or 1 year of age. Burns, scald burns are usually the most common leading cause of admissions in infants and young children, and it only takes 3 seconds for that little one to maybe pull that pan off of the counter. So make sure that you teach parents to move that handle so it's not where they can easily reach it. Sunburn is another is another reason for burns, and use a sunscreen, but they're usually not recommended under 6 months of age. So avoid any hot liquids, electrical sockets. Crib safety, make sure the crib slats and are okay and there's no lead paint, especially in our older cribs. The mobiles are far away. The blinds, because some of the blinds have lead in them, and blinds can also lead to strangulation of children. Falls, always have a hand on the child. Gates near stairs, walkers not recommended due to the child's age and fall risk. Lead exposure, inhaled lead dust with any kind of renovation of older homes, at risk, especially when they start walking over 6 months of age. So make sure you teach parents about childproofing their house, and latex balloons are not, there's such a high risk of aspiration and of choking in infants, so it's very important that balloons are not near infants. Accidents and prevention in toddlers, injuries, motor vehicle accidents, drownings, huge, poisonings, and burns are real important in a child with the toddler. Remember the proper use of car seats, that forward facing, can be after 1 year or at 20 pounds. Accident prevention for the preschooler, the booster seat is recommended. Remember, they're at high risk for child abuse, sexual abuse. There's fire, burn, and safety, fire alarm safety, personal safety. It's important that you teach them to say no to strangers. So it's important that you practice escape plans. Put firearms, unloaded guns, safety locks should be on. They should be secured. They should be locked somewhere where they cannot get into it. Sexual abuse perpetrators that usually are known, they're usually trusted. Make sure that you look for signs for child abuse, signs of burns, donut shape, circular shape, shyness, withdrawal. They're very withdrawn. They frighten very easily. Issues related to the school-age child, adjustment to school. That's important at this age. Self-care children, our latchkey. Obesity, rampant with our, they're starting earlier than school age. They're starting in preschool. Obesity, meals on the run. We're all so busy that we get our food fast and furious. There's a lot of stress with our children, depression, and we have to look for that. We have to look for, the child that wants to sleep all the time, that's not interactive. And that's important with our school age. Accident prevention, safety education, car, fire, burns. Our and they're more into sports, so safety gear is real important for them. Behavioral problems, ADHD. Symptoms usually present before age 7 and present in at least 2 different settings, so maybe at home and school. Inappropriate attention, impulsivity, hyperactivity. It can go from mild to severe, and there's a wide gap between their verbal and performance skills. Remember Ritalin and Dexedrine, the most common drugs. Watch for nervousness, insomnia, increased blood pressure, decreased appetite, weight loss, and growth. So your height and weight is extremely important with your child that has ADHD. Also related to school-age children is enuresis, which is bedwetting, and that's defined as 2 times a week for at least 3 months. There can be organic and psychogenic factors Usually it ceases between 6 to 8 years of age in boys. And we have to rule out organic structural problems such as any kind of kidney, neurological deficit, or diabetes. But there can be psychogenic emotional factors, and there may be a family history, and it could be childhood depression, and it could be sexual abuse. So, but remember, we always have to rule out the organic, the physical first. School phobia is real. There's severe anxiety or fear of school-related experiences. The child may complain of anorexia, nausea, vomiting, diarrhea, dizziness, headache, tired, stomach aches. Very subjective types of symptoms, and the signs and symptoms subside when the child can stay home, and especially on a holiday or a weekend, they'll all of a sudden get better. So parents must be firm but gentle. That immediate return to school is crucial. You need to speak with the parents need to speak with the teachers and counselors, but it does not help the child. Your rewarding behavior, if it is truly a school phobia, and it's been identified as a school phobia, you're not doing the child any good by keeping the child at home. There's some issues related to the school-age child as well as there's head lice. Remember that you have to treat the entire family. Linens need to be washed. No sharing of combs. Keep all the stuffed animals in the bag for 2 weeks. Very important. Bullying, you need to talk to the adult. Watch for signs such as bruising, loss of items. Talk to them about school. Open-ended questions, important. Talk to them about their friends, which ones they like the best. Always go to the positive, and then maybe they'll tell you about, that old bully at school. And you need to encourage parents to talk to an adult at the school level. Food allergies, always monitor, your ABCs first. Usually things like peanuts, so we always want to assess, our patients for those. Issues related to the adolescent. Body image is a huge concern with our adolescents. There's a lot of eating disorders, obesity on the rise. So they have self-image problems, anorexia nervosa. Etiology is still unclear, but there is a psychological component that's present, and bulimia as well. Smoking, still, an issue related to adolescence. Substance abuse, and you look for changes in personality, behavior, physical appearance, any kind of defense mechanism, especially anxiety, fear, anger. Remember, pregnancy is an issue related to adolescence, the use of contraception. Prenatal care is important. If you have a child that comes to you, I say child, adolescent that comes to you that says that they're pregnant, the very first thing you want to guide and direct them to do is have prenatal care done, and educate them on reduction, of any kind of risky behaviors. Also, sexually transmitted diseases are on the rise. Suicide. Look for the warning signs. And we're going to go over that in a little bit. Depression, change in habit, withdrawal, check for any firearms, assist as needed, and educate the parents, about the warning signs. Car safety, seat belts important. Violence towards others, they need there's control issues, especially with our male adolescents. Our male adolescents, especially if they've been in abusive situations at home and their father has abused the mother, and they're dating a girlfriend, they're going to have some control issues, and they may be violent, and whether it is verbally or physically violent to the girls that they date. So it's real important. Also, there's lawnmower accidents and any firearms. You hear more and more and more about adolescents having access to guns. Huffing, inhalant abuse, and they inhale anything. There's an intervention clip on YouTube that I have also included in your course content on huffing. Maltreatment of children. When we talk about child physical abuse, child sexual abuse, child emotional abuse, child neglect, Munchausen's by proxy syndrome. This is basically when you deliberately make the child sick in order to get attention. A failure to nurture, very important for us as healthcare providers to check or look at the bonding between that child and the family and how important and how strong that is, and always look for any kind of bruising. Sexual abuse, you may have an enuresis child. You may see it through their play. Remember the play is the work of the child, so you can see how things affect them through their play, and document that as objectively as you can in the chart. Depression and of children and adolescents. Usually there's a period of 2 weeks with 5 key elements that persist and are present. Sad or irritable mood, loss of interest, change in appetite or body weight, difficulty sleeping or oversleeping, being slowed down, fatigue, loss of energy, feelings of worthlessness or excessive guilt, decreased ability to think, and any kind of recurrent thoughts of death that they have vocalized. Or in their drawings. In their drawings, you'll a lot of times see that with our depressed children and adolescents. In our infant, usually they're listless without any kind of physical cause, and usually there's a failure to respond, to the caregiver, and they usually have those failure to thrive type symptoms. Adolescent dating violence. Talked a little bit about this before, but it is a learned behavior. They tell their partner what to wear, the permission to go, or who they can be with, who they shouldn't be with. They make their partner do something or not do something unwillingly. They destroy the property maybe of the girl that or guy that they're dating, and usually I say it's for the girl because it's usually the male has more of the violent tendencies. Threatening after their breakup, and they keep contacting them after their breakup. And let's go back just for a minute and remember that the adolescent male wants control. This is all behavior that he wants to control the female partner. Homicides, 1/3 of all homicides occur in adolescence, and they stem from history of abuse in the home. There's either distant, passive, or absent fathers, dominant, overprotective, sexually inappropriate mothers, violence between the family members, there's some turmoil in the home, and there's feelings of distrust in the home. Suicide is the 3rd leading cause of death in adolescence. Usually these adolescents are very overwhelmed and they're anxious. They have a lot of peer pressure. Females engage in suicide about 15% of the time. Males, carry it out 85% of the time. So there is a difference between the genders when it comes to suicide. Depression is a common finding. Substance abuse is another common finding. And I thought it was interesting, gays and lesbians are 5 times more likely to commit suicide than a heterosexual adolescent. Lead poisoning, this is our last slide, and it's lead-based paint, can be in contaminated soil, can also be in certain vinyl mini blinds, living near a major highway, contact with imported jewelry. So lead-based blood studies are done. They'll do, especially if the child has anemia. So they will do that in a pediatric office, especially with more of a high-risk patients. The next slide is just an empty slide, and I thought that I would just kind of recap. This has been a very long lecture, I know, and I thought I would just recap and do kind of a review for you on things that I've said is important throughout this hour and a half, and what are some things that you really need to focus in on for your upcoming opportunity to succeed. I want you to make sure that you go over the developmental stages of your children and what they are able to do, what they can do. The psychosocial stages are very important, especially with our safety and injury prevention, especially with our toddlers, our preschoolers, adolescents, those developmental stages. We talked a little bit about temper tantrums. And remember that temper tantrums in children that are toddlers, it's usually because they can't express themselves verbally. So it's important for you to remember that. Remember also that we put our children at risk when they're in a home with passive smoke. So we put them at risk for SIDS, and we also put them at risk for any kind, especially upper respiratory types infections. Remember that we also want our children that are adolescent, we want to make sure that we check their behavioral changes for any kind of sign or symptoms of maybe using alcohol or becoming depressed, and usually any kind of substance abuse. So we would look at any kind of mood swings or any kind of changes in their clothing, or maybe changes in their selection of friends. We also talked a little bit about school phobia and some of the signs and symptoms of school phobia and what some of the interventions are. We also talked about never giving aspirin to a child, especially if they have chicken pox, that they have any kind of virus, because it can lead to Reye's syndrome. We talked about one of the causes of enuresis, and we have to rule out physical or organic causes of enuresis. We also talked about assessing the weight of a 5-month-old. We want to, they should double their weight by 5 months old, and they should triple their weight by 1 year. We also talked about some childhood depression, decreased appetite, more time alone in their rooms. They may have a history of nighttime nocturnal enuresis. So we need to to provide information to our moms and dads and the importance of looking for those kinds of signs and symptoms. Anorexia nervosa, knowing that it results in a severe weight loss, usually in the absence of any kind of obvious physical causes. Chronically ill children, we talked a lot about children and their need to play, and chronically ill children are the same, and usually their play is usually an indication of their response to the treatment that they're getting in the hospital. We talked a lot about ritualistic behaviors and how that provides a sense of security for the preschooler and for the toddler, and how important that is. We talked about some of the physical findings that you may see with infants and children. We talked a little bit about the anterior fontanelle at age 12 months being slightly open, which is a normal finding. We talked about poor body image with an adolescent that's overweight. We talked about that. We talked about ADHD and the importance of height and weight with our patients that are on Ritalin. Imaginative play in a 4-year-old can be that can provide therapeutic play, so that you can see how they're thinking, and some of their responses can be done through dress-up clothes. So it's important that our preschool child gets to play, because that's the work of the preschool child, is their imaginative play, and they can do that through dress-up clothes. When you're talking to a group of high school juniors, the nurse primarily focuses on motor vehicle accidents. Very, very important with them. We talked about dating and the controlled boyfriend who is abusing his girlfriend. We talked about that. We talked about head lice and the importance of making sure that all the stuffed animals are in plastic bags, and the importance of teaching the family about head lice. We talked about the adolescent and suicide. We also talked about the growth and development of children. There's a sequence of developmental milestones that I kept reiterating throughout the lecture that's predictable. It's very predictable. We also talked about school phobia and some of the signs and symptoms of school phobia. The play is the work of the child, very important. So you need to know what types of play is important with children of certain ages, or just have a concept of that. We talked about eating and nutrition and the importance of letting the 3-year-old feed himself, how important that is. We talked a little bit about allergies and how important it is to assess, the ABCs. We have talked about the introduction of solid foods during infancy. We talked about referring our adolescent to prenatal care that comes in and tells you that she is pregnant. We talked about all the safety needs of our children in different developmental stages. We talked about how to put a car seat in for infants versus one that's over 20 pounds. We talked about temper tantrums and timeouts, and it's important that you look at your videos on that. Remember that sexually transmitted diseases also can lead to pelvic inflammatory diseases in our adolescents, and that can make the young girl sterile, so it can have some devastating effects on the reproductive tract of our affected adolescents. Therapeutic communication is very, very important with our patients and families. And remember to allow them to have choices, our children. We talked a little bit about immunizations and the importance of immunizations. And I told you do not memorize the chart for immunizations. I don't think that's what you need to do. Just know who's at greater risk, and we talked about that. Nursing considerations for our children that are and families that maybe have a son or child, a son or daughter who is dying. It's important that you involve the family in the decision-making process and make sure that they spend time with their dying child and loved one before and after the death. We talked about the single most important factor to consider when you communicate with children, and that's the developmental level of the child. And remember that when you deal with school-age children, that you're going to give factual explanations of the disease, the medications, and or the procedures that you're going to be doing with them. Okay, so that ends this lecture. I know it's long. I know it's probably tedious for you to listen to me for this long. However, you can pause. That's why I kind of put them in 3 different sections, so you can pause and come back to it. So I hope that helped with a little review at the end. Wish you well, and you'll do fine. And I will see you on Thursday. Thanks.